All right, good morning, guys. It is, what, Tuesday? Tuesday, November 24th, on our way to Thanksgiving. And today, of course, I'm still at home. We have some issues with the kids as far as their school is concerned. So I'm going to be doing it from home. We had a very good, I'm breaking up. All right, there we go. We had a really good session on yesterday, covered a lot of material, a lot of medications. And today we're going to continue that path. We're going to knock out some medications, talk about a few things. I may throw up a couple of quizzes on there for you to work, like classwork type of things. And we're going to do that today, and then I'm going to maybe finish off with a discussion for this evening. So it might be kind of quick today because of the daycare thing. All right, so let me pause for a second and get this pulled up for you. Okay, so the first thing we're going to do this morning is I'm going to pull up a vocabulary quiz for you to do. It's not full grade, but I do want you to work on this, and we're going to go over it. I want to hear what what answers you think went with what. Okay, terminology is very, very important, especially in pharmacology. Okay, terminology is very, very important, especially because of the way it may mean something totally different for how drugs work together. Okay, you need to know those phases: pharmaceutical phase, pharmacokinetic, and dynamic, and all that kind of stuff. You need to know that down packed. All right, so I'm going to share my screen. All right. All right, let's do the first. Let me just say that we'll do the first. It's kind of hard to put them all on there. How many? There's 20 of them. 20 words. Trying to do them without the answers popping up. So let's just do that. Do 1 through 17. If you don't see the answer to one of them, then it might be down here, one of the ones that you can't see. But just try to do 1 through 17 right now. I'm going to pause the recording while you guys work on this terminology quiz. All right? So you just like, for instance, number 1, indication. Indication. Then you would come down here and find out which one of these terms or which one of these definitions will match indication. So I'm going to do the first one together. No.
Mr. McCarthy.
Yeah.
We did this last night for homework.
Huh?
We did this last night for homework.
Oh, good, good. I didn't know if that was on the homework or not. So you already got that then. Okay, good. So let's go over that one then. So make sure everybody's on the same page. Matter of fact, I probably can just pull up the answers because I think everybody pretty much turned in the homework. Let's do this. Make sure you got the right one. All right. Number 1, indication. Indication should be D, the reason for giving a drug to a patient. Okay, the reason for giving a drug to a patient is the indication. Number 2, tolerance. Ms. Woods, what you get for tolerance?
I got P.
P, increasing dose needed for effect. Okay, number 2 is P. Good. Number 3, adrenergic. Ms. Cummings, what you get for adrenergic?
I have F.
F, drugs that mimic the effect of epinephrine. That will be adrenergic. Good. Adrenergic, aka sympathomometic, right? Good. Number 4, vasopressor. Vasopressor. Miss Scott. I'm sorry, I don't think she's on here. Let's see who's on here. Miss Rose, what you get for vasopressor? I, drug that exerts a
Yes.
constricting effect on blood vessels. Good. Number 5, pharmaceutical. What is the pharmaceutical phase? Or what does pharmaceutical mean? Let's see, make sure I got everybody on. Kayla, what you get for pharmaceutical?
J.
Okay. The phase related to the route of administration. So what is the pharmaceutical stage or phase for respiratory medications? Anybody?
Inhalation.
Inhalation, good. All right. Number 6, muscarinic. Miss Woods, what you get for muscarinic?
C.
C, the effect of acetylcholine on the smooth muscle. Acetylcholine goes to the muscarinic site and causes constriction, right? The smooth muscles constrict when acetylcholine is on deck, right? When acetylcholine is on deck, the smooth muscles constrict. What happens to the smooth muscles, anybody, when epinephrine is on deck? What happens to the smooth muscles when epinephrine is on deck? Anybody? When epinephrine is used as a neurotransmitter, what is the effect on the smooth muscle?
Dilate.
Dilate.
Dilation. Dilation. All right. Pharmacodynamic. The pharmacodynamic. Miss Rose, what did you get for that? I mean, not Miss Rose, Miss Cummins. What you get for pharmacodynamic?
I have L.
Let's see. Phase related to the mechanism of action. I believe that is it. Pharmacodynamic number 7 is L. Good. Good. That's how the drug does what it does, right? How it does what it does. Okay. Now, since we know that the pharmacodynamic is the phase related to the mechanism of action, how that drug goes about doing its job. So what is the mode or the mechanism of action of our sympathomometic drugs? How does it do what it does? What are those steps we learn? Let's just say, Kayla, what's the first step? When you inhale a sympathomometic drug, what's the first step that happens in the body? You remember, Kayla?
No.
All right. Ms. Rose, you remember what the first step is?
Activate. I don't know how to pronounce these words.
Adenylate cyclase?
Yeah, adenate cyclase.
Good. Good. That's the first step. All right, Ms. Woods, what's the second step that happens?
I don't remember.
Huh?
I don't remember.
Okay. Ms. Cummins, what's the second step? After the activation of adenylate cyclase, what happens next?
Increase the ATP to 3.5.
Good. So it converts, not increases, but it converts ATP into 3,5 AM, not 3.5, but 3,5 AMP. Okay, good. 3,5 cyclic 3,5 AMP. All right, so the adenylate cyclase is activated, and then Ms. Cummins said it converts ATP into cyclic 3,5 AMP. And then Ms. Rose, what happens as a result of that? What happens?
Bronchodilation.
Bronchodilation. Good. That is the pharmacodynamics of your sympathomometic drugs, aka your adrenergic bronchodilators. That's how they do what they do. All right. They go to their receptor sites. What are the 3 receptor sites for the sympathomometic drugs? Anybody?
Alpha, beta 1, and beta 2.
Good. All right. And alpha is your vasoconstriction. Beta 1 is your cardiac effects, and beta 2 is
Increased cardiac.
beta 2. Beta 1 is increased cardiac. Beta 2 does what?
Bronchodilation.
Bronchodilation.
Dilation. All right, good. Y'all studying, okay? Sounding good. All right. Number 8, side effect. Side effect. Ms. Woods, what is side effect?
E.
E, an undesired effect of a drug. Good. What about number 9? Miss Woods. No, I think I just said Miss Woods. Miss Cummins. Number 9. Absolute contraindication would be what?
I have B.
B, absolute. Let me see. B says drug may not be given for any reason. Good. That's right. All right. Number 10. Let's see who got number 10. A leukotriene. What are leukotrienes? Miss Rose, did you get that?
Yes.
S. Compounds that produce an allergic or inflammatory responses. Good. Good. You're reading. All right. Number 11. Madriasis. If somebody is experiencing madriasis, Kayla, what does that mean?
K.
K, dilation of the pupil of the eye. When that dilation of the pupil of the eye is called midriasis. All right. A lot of times, if somebody's okay, let's do some critical thinking now. Let's see. If somebody had an injury, like what part of the brain stem would the injury occur if a patient is experiencing midriasis? All right, I want you to think about that for a minute. What if a person got injured, your patient was injured on the brain stem or spinal cord? What part of the brain stem or spinal cord must the injury be at if the patient is experiencing midriasis? Think about that for a minute. I'm going to pause the recording and you can put it in the chat. Put it in the chat. Where would the injury most likely be if somebody is experiencing midriasis? All right. Let me check my chat and see what I got. All right. Kayla, yours looks good. Kayla said a high cervical injury. Okay. Kayla said, hey, why is it? Oh. Kayla said a high cervical issue, right? And that would be right, right? That would be right, because when I asked you guys, where would the injury be? Some of you are telling me different things. I'm talking about where on the body would the injury be? And so Kayla said the high cervical would give them Madriasis, because the high cervical is where the parasympathetic nervous system lies, up in the top of the brainstem, right? Up at the top of the brainstem, right? You got your brainstem, and then you have your spinal cord. The parasympathetic nervous system is up at the brainstem, which gives us constriction, right? It constricts the pupils. So if I have an injury to my cervical, high cervical, which is the top of your vertebrae, right? Some type of injury, gunshot, car wreck, break, whatever, up there, that's possibly going to injure or disrupt the parasympathetic nervous system. Therefore, when you're looking at your patient's eyes, they don't dilate. I mean, they don't constrict. They only dilate it, right? Because the parasympathetic side is pulling to close, and the sympathetic side is trying to open. So both of them working in conjunction together keep the eyes at normal, right? But if you get rid of the parasympathetic side, then there's no longer a drive to close or constrict the pupil, and now it's just wide open, because you have nothing but the sympathetic side acting, okay? So that's how, you know, that is a good critical thinking, how she used those steps to understand how I would arrive at this issue, okay? These are layers, right? Those things that you learned yesterday, and say, okay, well, if the parasympathetic side is the one that constricts, and my patient's eyes are just dilated, they won't constrict, then that means the parasympathetic side is not working. So where on the body would an injury have to be to knock out the parasympathetic nervous system? And it's the high brainstem, or I think it's some on the lumbar, right? But the lumbar would be more of the stuff working down here, like the uterus, the rectum, intestine, stuff like that. Those work toward that, okay? So good, excellent job.
Well, I also learned when I was in the OTA program that like blunt force trauma to the base of the skull can cause like eye blurriness and stuff. Yeah. So that's where I went with the high cervical.
Okay, good deductive reasoning. All right, so that's Madriasis. Antagonist, number 12, an agonist. I'm sorry, not antagonist, but agonist. An agonist, Miss Rose, what's an agonist? You still with me, Miss Rose?
G, yeah, G.
G, okay, an agonist is a, let me see what G say. Has receptor affinity and exerts an effect. That's it. It has an affinity for that receptor and it makes an effect, right? It goes to that receptor, steps on it, and causes a response, right? That's an agonist. Somebody who's always on your nerves, right? Somebody who knows how to go and push your button. They find your button and they push it. Same thing drugs are doing. They find the receptor that they want to go to and they push it. All right, that's an agonist. All right, number 13, pharmacokinetic. Pharmacokinetic. Mr. Simmons, did you do this sheet last night? All right, you might not be on yet. Miss Woods, what you get for pharmacokinetic, number 13?
T.
You said T as in Tom?
Yes.
Good. Phrase related to metabolism of the drug. That's the movement of the drug, right? That's the movement. You ingest it, right? It's got to be absorbed, metabolized, and excreted. That's movement. Pharmacokinetic. Kinetics mean movement, right? So the movement of the drug through the body from ingestion or inhalation to excretion. All those steps is the movement. Good. 14, Ms. Cummings, cholinergic. What does the cholinergic mean?
I have H.
H mimics the effect of acetylcholine. Excellent. That's what it is. If we have a drug that is a cholinergic drug, it's going to act like acetylcholine or the parasympathetic nervous system, right? It's going to do those things like constrict the lungs, constrict the constrict the pupil, make the heart rate go down, right? All of those things are cholinergic effect. That's why we take a drug that's an anti-cholinergic to keep that from happening in our lungs, right? And an anti-cholinergic drug that we use for breathing treatment is what drug? Anybody? What drug do we use that's an anti-cholinergic for breathing?
Albuterol.
Albuterol is an adrenergic drug. I'm looking for the anti-cholinergic drug that we do for breathing. Because cholinergic causes the lungs to constrict. So we have to take a drug that will keep it from constricted. So that will be an anti-cholinergic drug. And I told you there was one anti-cholinergic drug that we inhale to prevent constriction. What is that anti-cholinergic drug? Anybody?
Atropine?
Not atropine, but that is an anti-cholinergic, but it's the other one.
Albuterol.
Oh, it's Atrovent.
Yeah, Atrovent.
There you go. Atrovent. Atrovent is a anti-cholinergic as well as atropine. Both of those are the only two anti-cholinergic drugs that we talk about. All right? Atropine.
Come back here. Sorry.
That's all right. And so those are the two drugs that we that are anticholinergics. Okay, we take the atropine in surgery to prevent the heart rate from dropping too low, right? Because we got them so sedated, right? But in respiratory, we use Atrovent, which is an anticholinergic that blocks the effects of acetylcholine and that keeps the lungs from constricting. Who can tell me what the trade name, the generic name for Atrovent is? Trade name?
I'm gonna try. You said Atrovent, right?
Yeah.
Propropamide, propropamide.
Close enough.
Ipratropium.
Ipratropium bromide or ipratropium bromide. Ipratropium bromide. Okay, that is Atrovent. Good, good. All right. The next one is Antagonist. Mr. Simmons, can you hear me? Or can you respond?
Yeah, I can hear you.
Okay. This sheet right here, what do you think is the answer for number 15, an antagonist?
I got Q.
Q, let's see here. Has receptor affinity but produces no effect. Excellent. It goes to that receptor, but it doesn't have an effect. It actually blocks the effects of anything that touches that one. So an antagonist kind of protects you. An agonist is somebody who goes and finds your button and pushes it. An antagonist will be somebody who stops that agonist from pushing your buttons. All right. So an anticholinergic is also an antagonist of acetylcholine, right? So ipratropium bromide, which is an anticholinergic, would be an antagonist of acetylcholine because acetylcholine is the cholinergic response. Okay. A lot of terms. That's why I told you, you've got to study, read, and stay on this. And it looks like most of you have. I'm impressed with some of the answers that are coming through the very next day. All right, the next one is tachyphylaxis. Tachyphylaxis. Miss Woods, what you get for tachyphylaxis? R. Rapidly developing tolerance. Good. Somebody who's getting their tolerance to a drug increases really fast. They gain a high tolerance really, really quickly, right? All right, somebody that drunk a pint of liquor one day and then got, you know, a feeling it, but the next day they had to drink a whole fifth. It's like, damn, you jumped up real quick. That's tachyphylaxis, okay? 17, onset. Onset, what does that mean, Ms. Rose? What does onset mean? Huh?
I don't know if my computer is freezing or yours is freezing.
Might have been,
It's mine too, so.
might be me. I don't, but that's Miss Rose. I'm asking you. Onset, 17. What does onset mean?
I got N.
In? How long it takes for the drug to start working? Good. It's the onset. So, because that's what you're going to learn as we go into those long-acting bronchodilators. We got those short-acting, right? That, you know, they're rescue drugs. Those short-acting sympathomometic or those specific sympathomometic adrenergic bronchodilators that we talked about yesterday, the ones that you got to remember, the bronchosol, isoproterenol, albuterol, all those you learned, that group is a rescue drugs. They affect you immediately. They might not last real long, but they affect you immediately, okay? The long-term bronchodilators, like the salmeterols and the other ones you're going to learn today, they last for a long time. Once they get you in your system, they give you bronchodilation for a very long time, but they take a long time to kick in, right? They may take 5 minutes or 10 minutes to even kick in. And if you are in an emergent situation, you don't want to give somebody a long-acting bronchodilator because it's going to take too long to kick in. They want the medicine now, okay? They need the effects now. So onset is how long it takes to kick in, okay? All right, last couple ones. Peak effect, Ms. Cummings, peak effect. What is that? Number 18. Peak effect, Ms. Cummings. Can y'all hear me?
I'm sorry, I had stepped away. What did you ask?
Oh, number 18, peak effect.
M.
M, the maximum effect of a drug dosage. Good. When it's at its peak, when the pain is gone, right? You took a pain pill and, you know, it took a little while to kick in, but after a while you look around and say, ooh, my neck don't hurt no more, right? It's at its peak effect. And then duration, of course, it's, you know, it's just duration. Well, number 19 would be what? Anybody?
O.
Duration is O, how long the drug lasts, and then half-life is what?
A.
A. How long to metabolize half the drug dosage? Good job, guys. Really good job on those terms. You're studying and you're reading. Okay? All right, let's keep on going. Let's do, did the drug dose calculations. Everybody's doing well with that. So let's go on with the lesson plan. Pick up where we left off yesterday. All right, so yesterday we started talking about, we got finished with those bronchodilators. We talked about their side effects to the adrenergic bronchodilators. Then we got into the backdoor stuff, right? How we can achieve bronchodilation or enhance it through another means, right? We talked about xanthines and what they do, how they block phosphodiesterase, right? And we said the two xanthines were theophylline and aminoalphalin, right? Then we got into the parasympathetic or the anticholinergic drugs, right? Which are Atrovent and Atropine. Atrovent, whose trade name is the trade name for ipratropium bromide, right? And we said we use that to block the effects of acetylcholine. So therefore, it's a anticholinergic, because the effects of acetylcholine make the bronchioles constrict, and we don't want that. And so to keep them from constricting, we take a drug that's going to block it. So not only is it an anticholinergic, but it's an antagonist of acetylcholine. Okay. All right. Atropine is the second anticholinergic drug that we use, and we usually use that one in surgery, right? Because we have them so sedated when they're in surgery. We don't want
You're breaking up.
Okay. We have them so sedated that we use atropine to keep that from happening. Okay, we keep the heart rate from dropping. All right, yeah, we had a little internet issues. I don't know what happened. Can everybody hear me now?
Yes.
Okay. All right. So again, I was talking about the parasympathetic, parasympatholytics, right? Remember, a lytic is anything that's against something, also known as a anticholinergic, also known as a agonist of acetylcholine. Okay. Thank you for telling me. Every time I break up, just let me know so I can figure out what's going on. All right. Then we got into the corticosteroids. We talked about steroids and how the steroids are treatment of inflammation. We give steroids for inflammation because sometimes asthma is not only just reactive airway disease, but sometimes it's also inflammation. So not only do you have constriction because of irritation, but there could also be some inflammation there. So instead of just giving albuterol or any one of the other specific sympathomomitic drugs, we can also give a corticosteroid to treat the inflammation component of that asthma, okay? And we talked about inhaled. We have some that are inhaled, and we have some that we take by mouth, right? So these are the side effects of the inhaled, side effects of the by mouth, which is systemic. All this is from yesterday, all right? We went over the aerosolized steroids. I'm not gonna go back over them again because we got so many to do today. So all of these were the inhaled corticosteroids that we talked about yesterday. Then we said there is a one medicine we give by mouth. One steroid that we give by mouth is prednisone, okay? And we talked about how you give a loading dose, right? You know, have that Metro dose pack where they give you, take these 10 pills right now, and then tomorrow take 9, then take 6, then take 5, like that. And so the first dose would be your loading dose based on your weight and, you know, based on your weight. And then we will check your levels in your blood to see if that's still there. Do we still see that medicine? And there's a certain level that we're looking for, right? The therapeutic level, right? So for instance, the therapeutic level of prednisone is 100 to 150 micrograms. If we can see that in the blood, you're good. If not, then we need to give you a little bit more, right? We give you enough to keep you right there, okay? Keep you at therapeutic level. Steroid can be given for 2 to 3 weeks, right? Long-term management of your condition. All right, now, today we're going into long-acting bronchodilators. Long-acting bronchodilators. These are the dilators that do the same thing with the sympathomimetic response, but they last so much longer, right? And not only that, but they take longer to take effect. All right, so let's look at some of the long-acting bronchodilators that you're going to have to remember, okay? Now, they're not going to ask you the beta 1, beta 2, and alphas of these, right? They're just asking you some basic things to remember for these, okay? Salmeterol xenophosphate, salmeterol xenophosphate, or just salmeterol, is the generic term for Ceravent. Ceravent, okay? Ceravent is provided as a DPI, which is a dry powder inhaler. A dry powder inhaler, 50 unigrams per blister. Now, when we talk about MDI, which is meter dose inhaler, versus the DPI, which is the dry powder inhaler, They both do the same thing. They both give you medicine. But the Metadose is a aerosol that you squirt, and the DPI is a dry powder that you inhale. And you're like, well, why dry powder? So you have to think about the way to breathe in a dry powder inhaler is different than the way you do an aerosol. What is the aerosol's key way to tell your patient to breathe to get good deposition of aerosol? What do we tell them?
Slow, deep inspiration.
Slow, deep with an inspiratory what?
Hold.
Hold. Okay, good. But with a dry powder inhaler, powder does not aerosolize. Powder does not float on the air like aerosol does. So when you take a DPI, we have to do that one fast, hard breath in, right? To just try to force the powder down into the lungs because it doesn't fly, right? So since it's not suspended on air, you can't do a slow, deep inspiratory hold. If you do that, it's just going to be on your tongue. For powder, you have to suck in one hard time for your DPIs, okay? And the way you get the powder is in a little capsule known as a blister, okay? So make sure you know what that is. A blister is a little capsule filled with powder. And when you put it into your DPI device, it crushes the pill and releases the powder, and it's ready for you to inhale. You inhale one quick time, and that's it. You wait till the next dose. I'm going to show you the difference between these in a PowerPoint that talks about the delivery devices. We're going to see the MDI. You're going to see the DPI, right? The small volume nebulizer, spacers that we use. All that in bright color on the PowerPoint, as well as when we come to class tomorrow. I will be back on campus tomorrow, and we'll go over some things in my hand so you can see it in my hand, okay? All right. So the Atrovent is the trade name for salmeterol xenophosphate. It's provided as a dry powder inhaler at 50 unigrams per blister. You take one blister 2 times a day, okay? Now, the Atrovent also comes in a what? MDI, all right? It comes in an MDI as well. And that as an MDI is 25 unigrams per blister, right, per puff. And so you have, not blister, I'm sorry, 25 unigrams per puff. MDI is the aerosol that comes out, right? And so how do I take that? 2 puffs twice a day. Now look at this, 12-hour duration. That's why it's called a long-acting bronchodilator. It's going to give you bronchodilation for 12 hours. So if it's giving me bronchodilation for 12 hours, what does that mean has been produced inside of my body that's going to last for 12 hours? What is that? What did I tell you was your friend? What we're looking to try to achieve? The production of what in the body? What are we trying to produce in the body that gives us bronchodilation? Anybody? Anybody remember? You just said it earlier. When we get bronchodilation, what are we doing? What are we producing? Did you say
The
something?
3-5 cyclic something.
Yeah, cyclic 3,5 AMP. You got to know what that is, because if you get a choice that has some different letters, you're going to choose the wrong one. Cyclic 3,5 AMP. That is your friend. The production of cyclic 3,5 AMP gives us bronchodilation. So the long-acting bronchodilator produces the cyclic 3,5 AMP and lasts for 12 hours. Okay, after that 12 hours, phosphodiesterase will come on deck and start breaking it down and go back to normal tone. Okay, unless we block him. All right, but look how long it takes for it to onset. Salmeterol takes almost an hour, can take up to an hour to kick in. So if I have a bronchospasm or asthma attack, I don't want to take something that's going to take an hour to kick in, right? So that's why F is here. It's a maintenance therapy only, not for emergency. Long-acting bronchodilators are for maintenance, not emergency. It is not a rescue drug. The only rescue drugs are those first bit of bronchodilators we talked about yesterday. Those specific sympathomometic drugs, those adrenergic bronchodilators that we talked about. Those are the rescue drugs. If you got an asthma attack, you better pull out one of those. If you pull out salmeterol, you're going to be waiting for about an hour before it kicks in. Now, when it kicks in, you good, right? But nobody wants to wait that long. Formoterol. Formoterol is the next long-acting bronchodilator. Formoterol is the generic name for Foradil. Foradil. It comes as a DPI, 12 grams per puff, 1 puff, BID. Again, it lasts for 12 hours. Now look at this one. It's a 5-minute onset. 5-minute onset. But even though it has a rapid onset and peak effect, it's better a maintenance drug than a rescue agent. Because think about this. Can you hold your breath for 5 minutes? Who in here can hold their breath for 5 minutes? Nobody, right? I mean, you might can, you know, a diver or somebody, a swimmer or something. I don't even think you can go that long, but 5 minutes is an eternity when you can't breathe, all right? 5 minutes is an eternity. So this is not a rescue. Just because it takes 5 minutes, yeah, if it's a pain medicine that kick in 5 minutes, that's a different story, right? You might can deal with that. But breathing, I can't breathe, and you're going to tell me, all right, about 5 minutes you'll be able to breathe. That's a long time. That's a long time. So it's still considered a maintenance rather than a rescue agent. All right. Those are the two long-acting bronchodilators. Okay. Now we have some prophylactic drugs. What's prophylactic mean? Somebody tell me what prophylactic means.
Preventative.
Preventative. Something that kind of helps prevent, right? In the future. You go from patient comes in and as an emergency, you give them his albuterol or his bronchosol or his isoproterenol, any one of those, right? And open them up, right? We may even give them a little Atrovent to block the cholinergic response of constriction, right? We may even give them a little theophylline that it would take away phosphodiesterase for a while to let them get some relief, right? So we get them in some relief. We even prescribe them a little bit of steroid, right, to help the inflammation. The doctor may send them home on some long-acting bronchodilators and some prophylactic drugs, so this never happens again, all right? Prophylactic drugs are drugs that prevent an asthma attack or whatever in the future, all right? If you take it every day, then you should not have these effects or these attacks, right? Now you can, but if you don't take your medicine and they get out of your system, now you open up to these attacks again, and we start all the way over again at ER, you know what I'm saying, going to the floor. Hey, you should have took your medicine, you weren't compliant, so this is why you back in here, right? Or you kept smoking and you kept staying around those irritants, and now here we are again, right? So if they take these prophylactic drugs like they're supposed to, they will have fewer hospitalizations from the same diseases process, okay? So it's 8:53, let's just say 55. Come back at 5 after 9, we'll break right here and come back and talk about the prophylactic drugs. I'm going to stop the recording and we're going to come back at 9:05, excuse me, and talk about the prophylactic category of drugs. All right. So prophylactic drugs, we already said that prophylactic was something that's going to help prevent an issue. So the first ones, and sometimes you're going to see that sometimes these will start having combinations of other drugs, right? Like fluticasone and salmeterol. Fluticasone and salmeterol together is called Advair. I'm sure you guys have heard of Advair before. That's that purple disc. Right? There's a purple disc medicine that they talk about on TV all the time, and it's called Advair. All right, I'm gonna pull up a picture. Advair discus. All right. All right, here we go. Let me show you. Let me do a new share. This right here. I'm sure you've all seen this before. This is Advair. This is a discus, and it's a dry powder inhaler. It's an example of a dry powder inhaler. Dry powder inhaler. Can y'all hear me?
You was breaking up a little bit, but I think you're good now.
Good. So it's a dry powder inhaler, okay? Advair. Advair is fluticasone and salmeterol. I know you can't really see it right here, but that's what you just saw in the lesson plan. Fluticasone and salmeterol together is called Advair. It looks like this. It's a purple disc. What happens is you open up, this is the mouthpiece right here. You open up the mouthpiece with this part here, it will close over, okay? When you open it up, you expose the mouthpiece. Then you pull the trigger down. Right here, you'll flick this down, and that will load the blister, okay? That will load your blister. It is now ready for inhalation. Put your mouth right here and one hard time. That's how you take Advair, okay? That's how we would take Advair, okay? So Advair is a mixture of fluticasone and salmeterol, okay? Fluticasone, let's see, what was fluticasone? Can y'all remember what fluticasone was? Here it is right here. Fluticasone is a steroid, corticosteroid. See that? Look, corticosteroids that we inhale. So we have a mixture of fluticasone, which is a, okay, go get it. Go get it. Fluticasone is a steroid mixed with a long-acting bronchodilator, salmeterol. So you put those two together. See how they're putting stuff together? They say, we're going to do a long-acting bronchodilator, mix it with a steroid, and call it Advair. That's all that is. And it comes in 3 strengths. The deep dry powder inhaler comes in, it's either 100 to 50, 250 to 50, or 500 to 50, okay? What does it say? Maintenance only, not for emergency. All right, hold on one second. All right. The next one was Chrominem Sodium, right? Chrominem Sodium, also known as Intol. It is a drug that stabilizes the mast cell, M-A-S-T. The mast cell is a cell in the body that houses histamine. How many of you have ever heard of the word histamine or antihistamine, right? Or if you haven't heard of it, histamine is like something that makes your eyes water, makes your nose run, makes you sneeze, makes you cough. It can give you an asthma reaction, right? From all of the pollen and all of the dust in the air. And so now I'm going to show you how that works, okay? The mast cell works like this. Okay? Mast, M-A-S-T, cell. And inside of the mast cell is histamine. All right? This is your mast cell, right? And inside of the mast cell is filled with histamine. Well, as long as the histamine is inside the cell, you don't have a problem, right? We don't have a problem. That's where it's supposed to be, okay? But sometimes animal dander, dust, whatever you might be allergic to, pollen, when the dust and pollen get on top of the mast cell, it starts to what we call degranulate or break down. Now the cell wall is starting to tear up. And once that mast cell wall deteriorates, like say you got pet dander that touches the wall, or your pollen and dust mites and all these things that we're allergic to. When it gets on the mast cell wall opens up. Okay, if the wall opens up, then what comes out? What is this that comes out?
Histamine.
Histamine. And so once histamine is released into the system, that's when you sneezing, runny nose, runny eyes, itchy eyes, all of this stuff, right? Those things happen when you have histamine release. And so we have to take drugs that are antihistamine. So when you do go outside and the pollen tears up your mast cell, the histamine comes out, but it cannot cause an effect because you have medicine inside of you that block the effects of histamine, okay? So that's what our Chrominem Sodium does. The Chrominem Sodium protects the mast cell wall. It gives a coating onto the mast cell wall so it can't break down. So when pet dander and all that come into the mast cell wall, it can't get in. Pet dander, pollen, dust mites, whatever you're allergic to, grass, you know, all those kind of things that would go outside and you start itchy eyes, watering, all of that. That will have no effect on the mast cell if the Chrominem Sodium is protecting it, okay? If the Chrominem Sodium is protecting, so say this is the mast cell, right? This is the mast, I'm using whatever I got, okay? Don't laugh. If this is my mast cell, then it's protected. The histamine on the inside of that mast cell is protected, right? It's inside, causing no problems. But once I crack this mast cell and the wall starts to break down, then that histamine that's inside of this mast cell starts to come out into the system. Once it comes out in the system, that's when it starts causing problems. And not only is histamine in here, but sometimes leukotrienes are also in there. So when histamine come out, it causes a problem. When leukotrienes come out, they cause a problem, right? Leukotrienes cause swelling and edema and all kind of airway issues, okay? And so as long as they're inside of the mast cell, we're good. But as soon as they come out, we have a problem. So what does Chrominem Sodium do? Chrominem Sodium will do this. As the Chrominem Sodium gets into the system, Chrominem Sodium will put a protective coating on the mast cell. All right? So that's what Chrominem Sodium does. Puts a protective coating over the mast cell. So now when pet dander, pollen, and everything that you're allergic to comes to the mast cell, it bounces off, because it can't get inside. Because if it gets inside, it's going to release the histamine and leukotrienes. And so that's what Chrominem Sodium does, all right? So throw this away. Chrominem Sodium is the generic name for Intol. So let's go back to the, I hope that demonstration helped you. I had to use what I had. That's what real G's do. All right. Chrominem Sodium, aka Intol. It stabilizes the mast cell, thus preventing histamine release, also known as degranulation. It is, why do we use it? It is indicated for the management of chronic extrinsic asthma. Extrinsic asthma is anything that causes an asthma attack from outside the body. That's extrinsic. Extrinsic asthma is anything that causes an asthma attack from outside the body. So what will cause, what is the asthma called when caused by something inside the body? What's that called? What would you think it'd be called? Anybody? Anybody? If extrinsic asthma is causes from stuff from outside the body, then what type of asthma happens from intrinsic? Come on now, intrinsic. And intrinsic will be stuff like stress, right? You can be stressed out and have an asthma attack. You could take aspirin, and aspirin can trigger an asthma that's coming from inside. Laughter, if you're somewhere laughing at somebody so hard, you go into an asthma attack. Those are intrinsic asthmas, right? Well, Chrominem Sodium don't protect from stuff that's happening on the inside. It's helping from stuff that comes in from the outside. Inhaling pollen, inhaled pet dander, inhaled dust mites, stuff like that, that get in there and cause a problem with that mast cell, okay? So it's used to stabilize the mast cell for your chronic extrinsic asthma patients. Those are your asthma patients. That's all, you probably know somebody who's got asthma real bad and he can't even play, right? Every time he play, he got to have his little inhaler and his little chest is always up all the time. You know, those type of patients you can tell just got bad asthma, chronic asthma, right? Then this is a prophylactic drug we can give them to keep him from having an asthma attack if he has extrinsic asthma, okay? All right, prophylactic requires about 2 to 4 weeks to reach maximum level. So the peak effect or the therapeutic level does not happen until about 2 to 4 weeks for Chrominem Sodium. So you see, it's not a emergency dose, right? It's not, just because it's used for asthma does not mean it's used for emergency asthma. You use it later. It's prophylactic, right? After about a month of being in the system, then it's fully protecting that mast cell, okay? May not be used during an attack, okay? You don't want to use it during the asthma attack. Now, how do we give Chrominem Sodium? MDI gives us 800 unigrams per puff. You do about 2 puffs 4 times a day. Or we can give it in a small volume nebulizer with about 20 milligrams per ampule. I showed you those ampules yesterday, right? Ampules will be like this. This is an ampule, also known as a unit dose, right? An ampule known as a unit dose. You just break it open, squirt it in your small volume nebulizer, and nebulize the treatment. The next prophylactic drug will be called Chrominem Sodium. Chrominem Sodium. It's just like Chrominem Sodium, guys, except it has some anti-inflammatory properties as well. Not only does it treat the mast cell, protect the mast cell, or stabilize the mast cell, but it also has an added ingredient to reduce inflammation, okay? So somebody who has extrinsic asthma and inflammation, we wouldn't give them Chrominem Sodium. Let's give them Chrominem Sodium, so that not only does it protect the mast cell, but it also what? Prevents or treats the inflammation, okay? So that will be Chrominem Sodium, and that's called Tylase. Hush, what is it? Come here. That's Tylase. Chrominem Sodium is the generic word for Tylase. What is it? What you want? Jesus. All right. It is indicated as part of a treatment regimen for the management of chronic allergic bronchitis and asthma. It blocks early and late asthmatic responses due to a variety of allergic and non-allergic triggers. Basically, you need to know that Chrominem Sodium is Tylase. Chrominem Sodium is Intol, okay? Chrominem Sodium is used to prevent degranulation of the mast cell, and Chrominem Sodium also stabilizes the mast cell, but adds an added ingredient for inflammation. They both take up to 4 weeks to reach maximum levels, and they are both given as an MDI or a SVN, okay? That's the basic thing. That's what you need to know, the difference between those 2 prophylactic drugs, all right? So look at your question carefully. It says, if it says patient has chronic extrinsic asthma and inflammatory asthma, what do you recommend? Don't say just Chrominem Sodium or Intol, but you want to say, let's do Tylase, out of here. Let's do Tylase, right? Tylase will be better because it has the anti-inflammatory response. Amari, go in there. Stop whining. Go in the room. All right. The next one is Leukotriene Inhibitors. I told you that mast cell has leukotrienes in it and histamine. Well, if those leukotrienes get loose, you have inflammation, edema, and bronchoconstriction. Leukotrienes are even worse than histamines. And so if we know histamine is the problem, we're looking for antihistamine. You can get that over the counter, right? You would take a drug that's a antihistamine, right? If leukotrienes is your problem, you need to take a leukotriene inhibitor. You'll need to take a leukotriene inhibitor. Sometimes people with allergies, bad allergies, they take both. You take one type, which is a leukotriene inhibitor like Singulair, right? I'm sure you've heard of Singulair. That's a leukotriene inhibitor. That's all it is. And then some other people will take another drug that's a antihistamine. Sometimes they take them together. So whatever one acting a fool in your body, it's going to stop it, okay? So leukotrienes are the mediators of inflammation, edema, and bronchoconstriction. Leukotriene activity can be inhibited by the synthesis inhibition or blocking the receptor. Just some fancy words for blocking it, all right? You need a leukotriene inhibitor so that it cannot cause problems. What are some of the leukotriene inhibitors? Or zarfalucas, and some of these are easy because they got Luke in the word, most of them, okay? Zarfalucas is the generic name for acylate or acrylate. They come in 20 milligram tablets. All right, Montelukast is the generic name for Singulair. Okay, Xyluten is Zyflo. Those are the three ones. There are three leukotriene inhibitors. Zarfalucas, which is acylate, Montelukast, which is Singulair, and Xyluten, which is Zyflo. Okay. Now, last one for that we're going to do for this part, antimicrobial agents. Now, before I do that, I want to show you the mast cell video. Okay, there's a mast cell video that I'm going to show. I'm not going to record it, but it is in your module. Okay, it is something that's in your module, so you don't have to worry about can you find it or whatever. It's in the module. Okay, so let me go to my screen, share the sound, and then I'm gonna go to the module. All right, here we go. It's called, this one right here, mast cells. There's a video right here called mast cells. I'm going to publish it so you can have it to watch. It's just a little quick video that kind of shows you a animation of how mast cells work. Okay, animation. Of course, when you see this, it says you're not doing it. Come up here to this right here and click this, and it will take you to the video. All right, immune function of mast cells. Let me stop the recording. So that, guys, was a quick little look at mast cells in action. The mast cell, what happens when that mast cell is degranulated and starts to release that histamine into the system. You have more mucus, you might have more issues. And so we give a drug that will block that response, right? We have the Chrominem Sodium. Chrominem Sodium will block that response, right? You got something, Miss Cummings? Did you say something?
No, I was saying that your volume was out, but it came back.
Oh, okay. So the leukotriene, I mean, and the histamine does that stuff. So that's why we want to keep it in the mast cell as much as possible, right? And so we do Chrominem Sodium to prevent the breakdown of the mast cell. If we want to prevent the breakdown of the mast cell and have a component that helps with inflammation, then we'll do Nitochrominem Sodium, right? Nitochrominem Sodium, which will give an anti-inflammatory response as well, okay? So those are two of the prophylactic drugs that deal with histamine, okay? Then we said the leukotriene inhibitors are also a problem. Once they are free in the system, they will cause inflammation, edema, and bronchoconstriction. And so we can take Zarfalucas, which is acylate, Montelukast, which is Singulair, or Xyluten, which is Zyflo, to block those leukotrienes, okay? Then we have what's called antimicrobial agents. When we have a parasite, either gram-negative or gram-positive organisms that are infecting us, we can take aerosolized agents that are antimicrobials to kill it, whether it be antibiotics, antivirals, antiprotozoals. Okay, so let's look at the three. The antibiotics that we take as or give as respiratory therapists will be either tobramycin or gentamicin. Tobramycin or gentamicin are two antibiotics that we give as respiratory therapists. Okay, they treat most gram-negative organisms like Pseudomonas, Acinetobacter, Klebsiella, and Enterobacter. So when somebody, Mr. Johnson, comes in with a lot of loculated secretions in his superior segment of his left lower lobe, right? And he has a fever, and he's short of breath, he's coughing up yellow secretions, thick, nasty secretions. We're going to take a sample of those secretions. We may give a little bit of hypertonic saline to get him to cough up some of those secretions. Send it to the lab and test it. If it comes back as Acinetobacter, we're going to give him some inhaled tobramycin or some inhaled gentamicin. Okay? If it comes back with Staphylococcus or Pseudomonas or Klebsiella, right? If it comes back as any one of these organisms, we know they can be treated with tobramycin or gentamicin. These antibiotics are often used with CF patients, cystic fibrosis patients, because they have a lot of nasty pus type secretions. Their secretions are pus. They coughing up pus, snotting out pus and mucus. It's very nasty. Okay, it's a very sad existence for cystic fibrosis. It's not a joke. Okay, and so we have to do a lot of different therapy to keep them clear. Okay. So not only are they getting the shaking vest, high flow chest wall oscillator, they're using PEP therapy, they're using flutter therapy. We're doing CPT on them, drainage, breathing treatments. I mean, it's just a long life worth of medications. All right. And so antibiotics will treat that. Those are the two antibiotics we use. All right. Now let's talk about antiviral. There's only one antiviral that we use. That's called Ribovarin. Ribovarin is an antiviral. So if they don't have a bacterial infection, they have a viral infection. And if they have a viral infection and it happens to be RSV, then we can treat it with Ribovarin. What is RSV? Respiratory syncytial virus. I know you've heard of that in babies. Sometimes our babies get sick with RSV. So if you're working in the NICU or the pediatric unit and your patient has RSV, you're going to be giving them Ribovarin. Okay? Ribovarin. Now, you can't give Ribovarin any old way. You can't give it in a regular MDI or a small volume nebulizer. Ribovarin must be given in a SPAG. That's a small particle aerosol generator. That's known as a SPAG. It's a special machine that you have to set up and use in order to give Ribovarin to your patient. Okay? If not, you're going to be inhaling the Ribovarin, which can cause you to have an issue, the virus. Okay? Cause you to have the virus, because when they're getting that Ribovarin, those aerosol particles are treating the RSV, but as they exhale, they're exhaling particles of that RSV. You don't want to inhale that exhale from that baby, because you could then be infected with RSV, which is respiratory syncytial virus. It causes bronchiolitis in infants. Okay, so that virus will cause the baby to have bronchiolitis, which is inflammation of the bronchioles. Okay, see how we use our terms? Litis or itis means inflammation. So bronchiolitis is simply inflammation of the bronchioles in an infant, which will cause them hard to breathe and all kind of issues. All right, has to be given in a what? SPAG. Has to be. All right. Now, finally, the last of the antimicrobials will be the antiprotozoal medicine. Antiprotozoals, and it's only one of these. Pentamidine. Pentamidine isoethionate, also known as Nebupent. pentamidine is known as Nebupent. That is the trade name. Nebupent is the trade name for pentamidine. This drug is used to treat opportunistic pneumonia caused by the Pneumocystis carinii, and that's also known as PCP. Okay, I'm gonna put PCP right here. PCP, Pneumocystis carinii pneumonia. Pneumocystis carinii pneumonia, also known as PCP. Pneumocystis carinii pneumonia, known as PCP. This is the patient who has it, AIDS. We see this in our AIDS patients. So a lot of times when a patient has HIV or AIDS, their immune system is severely compromised, right? And so you have an opportunistic pneumonia that's just like looking for somebody who has a weak system. Once I find the person with the weak system, I can go in there, set up shop, and kill them, okay? Most of your AIDS patients die from pneumonia, and that is Pneumocystis carinii pneumonia. It's a very bad pneumonia that affects the people with a very low immune system, and that's mostly your AIDS patients, okay? Once they find somebody or a host that has a very weak immune system, then it will attack them, mostly AIDS patients, and that's what kills them. AIDS doesn't kill them. It's the pneumonia that comes from the AIDS, okay? It also has a special way to give it. AIDS patients get pentamidine through a one-way nebulizer. So it must be given with a nebulizer with a one-way valve and a scavenging expiratory filter, and preferably in a negative pressure room or a hood. Like, wow. Oh, let me undo that. That's too much. Just highlight it, okay? You must give pentamidine this way. If you give it in a regular nebulizer, guess what you're picking up? AIDS, right? You're picking up the pneumonia that's they're breathing out, right? When they get those aerosolized particles, don't forget that. Those particles not only are good for deposition and penetration, but they also pick up the protozoa. They pick up the virus or whatever it is the patient has, like flu virus. It picks it up. So when they exhale right in your face. So you better be wearing a mask for your flu virus patients, but for your AIDS patients getting pentamidine, you need to use a one-way filter. That means they exhale through the one-way valve and not out into the air, okay? And it has a scavenging expiratory filter. That means when they exhale, it goes through this little filter that blocks all of the nastiness, right? You remember that filter I gave all of y'all to use? I said, keep this because, you know, whenever we use it on the Flutter or use it on some other device where you can practice, you put your own mouth on it and not nobody else's stuff, right? Well, that's a scavenging expiratory filter that I gave y'all. It's a bacterial filter that catches all of the nastiness, all right? Very effective. And they also kind of want the patient to either have a hood on while they're taking it or be in a room that has negative pressure. We spoke about rooms with negative pressure means the airway is reversed. So all of the stuff in the room gets sucked through the ceiling, okay? If I strike a match, it should go out and the smoke goes straight up. All right, real fast. That lets me know that that room is pressurized and the door must always be shut. If it's not shut, then it doesn't have its pull, okay? So pentamidine is given with a special nebulizer as well. Ribovarin is given with a spag, all right? So this is, you gotta be careful when you're giving this type of therapies, okay? And the last one is surfactant replacement therapy. Surfactant replacement therapy. We give surfactant to our premature or low birth weight patients, right? That get infant respiratory distress syndrome. IRDS is infant respiratory distress syndrome, right? That's because they won't open, right? We said surfactant allows the lungs to do what? Expand, right? It makes them smooth where they can expand, right? Like a wet sponge. If you don't have surfactant, you don't have the expansion properties, right? You have a very low compliance if you don't have surfactant. So when that baby comes out to breathe, if he's premature, his lungs have not developed the surfactant well. And what cells in our lungs produce surfactant? Anybody?
Goblet?
Type 2.
No, type 1.
Not type 1.
Type 2.
2. Good. Type 2 cells of the alveolar, of the alveolus or alveoli will produce surfactant. So when the baby is born too soon, his type 2 cells are not fully developed. And so since his type 2 cells are not fully developed, he hasn't produced enough surfactant. Therefore, when he comes out to take that human breath, right, his lungs won't do it. They're like, oh, sorry. And so now the baby can't breathe. He's going to drop fast, right, and die if you don't fix it. You're going to have to give him some surfactant immediately, okay? The two types of surfactant we give are Survanta and Exosurf. Survanta and Exosurf neonatal, okay? Survanta and Exosurf. So you shouldn't be hard at, surfactant is Survanta or Exosurf, right? It's not hard to remember those. That's surfactant replacement medicines will be surfactant or Exosurf, all right? How do we give it? We instill it down the ET tube. So that baby is going to have to be intubated. You're going to have to be able to put a tube down the baby's throat at birth. This is mostly done by the doctor, okay? When you have a premature infant, you're not going to really be intubating any premature infants, okay? When they come out or are delivered, the doctor will intubate those patients 90% of the time, okay? But then what you do is you instill the surfactant down the ET tube and then bag the little baby. So you bag it into the lungs, and eventually the lungs get easier and easier to bag, to ventilate. Because first they're going to be hard and stiff, right? And you can't overdo it because you'll bust his little lungs and kill him. So you just barely push him. You can feel the resistance. And as it gets easier, you put a little bit more. And now he's breathing normally because you have pushed surfactant through his little body. It's amazing. When we're talking about babies the size of your iPhone, right? Like this, in your hand. That's how small premature babies can be, all right? And so you have to be very, very careful and delicate if you're dealing with neonate babies, okay? All right, I'm gonna stop there because what I need to do for the rest of this, it needs really to have more stuff in my hand. There is a PowerPoint that I'm gonna use and then show it to you as we do the PowerPoint in class. I'm gonna have the PowerPoint. I want you to look at this PowerPoint, your assignment for tonight. Now, this ain't the homework, but this is an assignment I want you to do for the rest of the day, all right? And because I'm going to give you homework for tonight. But what I want you to do at this point is to go over the PowerPoint for the ways to give these medicines, because we're going to do that, and then we got to go into our mucinetics, all right? So tomorrow we're going to go over that PowerPoint, show you some of those modalities like the MDI, the spacer, the DPI, all those little ampules that I showed you the other day or yesterday. Go over those, let you touch them. If you're here, you can hold them and look at them, see how they work while we go over the PowerPoint. After that, we're going to talk about mucinetics, which is the movement of mucus, mucokinetics, right? What kind of drugs do we use to fight mucus? There are some specific drugs as well that are, you're like, wow, they work like that? It's amazing. And they also have mucomist that you're going to smell tomorrow. It smells like rotten eggs, but that's it. So if you smell it in the hospital, somebody's getting mucomist, right? That's something good for you to remember. That's how it smells. So that's why I want you to be there if you can tomorrow to go over these. After that, that's it, right? So we got the PowerPoint for the ways we give our medicines, and then we're going to talk about the mucolytics or the mucokinetics, and we'll be done with the information for pharmacology, okay? And so we'll do that. Tomorrow's Wednesday. We're going to do that. Then you're out Thursday and Friday. When you come Monday, we're going to do our lab, all right? We're going to have lab and review, not the test. Lab and review. Now, If you took off on Monday and you need to take the test Monday, you can. After class, you can take. I'll let you take the test. I'm not gonna say, well, I couldn't get off Tuesday. I got off Monday. That's fine. I'm not gonna let you mess up your schedule. If you like to take it Monday, you can take it after class. If not, everybody else is going to take it on Tuesday. Okay. So Monday when you come to class, we're going to have our lab. It's a nice amount of lab. Nobody's going to be interrupting us. We have the whole lab to ourselves on Monday. We're going to pass out the, let you mess with the DPIs and the MDIs, set it up, do breathing treatments on your patient, stuff like that, right? Make sure you have your lab book assignment with you, so work on that over your break. Make sure you stay in your reading, because I hate when we take the pharmacology usually always comes at this break, okay? And so when it comes at this break, during these 10 weeks, people come back from, I forgot everything, right? I went to my little Thanksgiving and didn't look at anything, didn't read nothing, and now I don't know. And that's not going to be our fault. You are responsible for this information. Actually gives you more time to study, to memorize. You shouldn't be going nowhere anyway this year with the coronavirus, okay? So anyway, tomorrow we'll do that. So tonight I want you to watch it. Here it is. I want to show you where it is, just so you can see for sure on the recording, can see what I mean. Right here.
We've all had cuts on our finger or wherever else on our.
Right here, the modules. All right, here it is right here, guys. Inhalation devices PowerPoint. Inhalation devices PowerPoint. Okay, I'm going to click it. Takes a little time. It's a lot of information. But anyway, you're gonna click the inhalation devices PowerPoint and look at that PowerPoint. Okay. Okay, wait a minute. I'm coming. Find this cup. Come on now. Okay, he's gonna find it. All right, it's just taking a little minute to download, guys. But we're still really early. It's just 9:50. I want it to come up so you can look at it right quick. And this is what I want you to study tonight or today. Go through it, look at it, so you can be familiar with this as much as possible when we go over it tomorrow. Okay. Yours will probably open up faster than mine because I got a bad Wi-Fi signal over here. All right, here we go. All right, here we go. All right, so here it is. Pharmaceutical devices. I don't know if I'm breaking up or not, but this is what I want you to watch today. I want you to look at it. All right, talks about that sympathetic, parasympathetic, gives you some of your medicines that have the stuff that you need to write down. Like, let's see, for instance, Isoproterenol is also known as Isoprel, right? It's a 1 to 200 ratio or 0.5% solution, right? Which is 5 milligrams per every cc, right? I already give you that. That's the dosage, right? And here it is, no alpha, but plus 4 beta 1 and plus 4 beta 2. And you give about half an hour to 2 hours short duration, right? This is an excellent table for you to look at for your studying. This is another one here that just kind of talks about how it works. Remember, we have ATP is turned into cyclic 3,5-AMP and gives us bronchodilation, right? And then phosphodiesterase comes in and turns it back to 5-AMP and gives us normal tone. But the parasympathetic side, or the cholinergic effect, will make you have production of CGMP, right? Which gives us bronchoconstriction, right? These two forces working against each other keep us at normal tone, right? This is trying to close me, this is trying to open me. So we stay at normal tone, all right? This is the Metadose Inhaler. I'm not gonna go over all of it, but this is the Metadose Inhaler. This is a spacer, the dry powder inhalers, right? Some comparisons of the two. The small volume nebulizer, how it works. You got the, You have the Aerogen, which is kind of like a ultrasonic nebulizer for medicines, right? And that's it. So I want you to go over those and look at those so you know them. I want you to know them down packed by tomorrow, okay? So only a few slides, all right? So only a few slides. I want you to look at that as much as possible, and we're going to have a few of those in our hand tomorrow when we're going over them, okay? Once we do that, we're going to go over the mucolytics part, and we're done, okay? Then Monday, we're done. You're going to enjoy your break. So actually, tomorrow is Wednesday, right? So we're going to do the PowerPoint tomorrow and the mucolytics part. Then, and that's it, right? You're on your break Wednesday because you're out Thursday and Friday. Good. Enjoy your break. It's going to be should be not real short tomorrow, but kind of like today. Won't be real long. I'm gonna get that knocked out, let you go, enjoy your week, your holiday. Come back Monday ready for the lab assignments, ready for the checkoff, and ready to review. We're gonna have some worksheets and some questions, some sample test questions, all of that, because we know it's a lot of terminology. I'm gonna have some oral questions. I got my cards in the classroom. I'm gonna go over some questions from RT210A all the way through pharmacology and just go through them, asking you questions, practicing, getting you ready, because the oral is coming, guys. We only have one more test after pharmacology, and then after that it's the oral and final, and you moving on, or you coming back. Either one is okay. You don't shake it off, and if you fail, shake it off, come on back. If you go on, good luck to you. I'm always here for you. All right, but we have to practice these orals. So Monday will be a full day, okay? Trying to get you prepared for Tuesday, okay? All right, have a good day, and be careful. I'll see you tomorrow in class. If I say the same, I'll be there tomorrow in the classroom. All right, have a good day.